Welcome to our presentation on predicting breast cancer recurrence. We compared several classification models to identify key predictors and evaluate their performance. This project was completed by Leah Han and Natalie Domikis, using the breast cancer dataset from the UCI machine learning repository. Breast cancer is the most commonly diagnosed cancer in women and the second leading cause of cancer death worldwide. Predicting recurrence after treatment is critical for tailoring follow-up care and improving survival. We used a dataset of 286 patients from the University Medical Center in Louisiana, available through the UCI machine learning repository. There were 9 predictors, including age, menopausal status, tumor size, lymph node involvement, malignancy grade, breast side, breast quadrant, and whether the patient received radiation therapy. The outcome variable is binary, indicating whether recurrence occurred. And in the full data set of 286 patients, 85 experienced recurrence and 201 did not. Our research question was, which predictors are most consistently linked to recurrence, and which classification model generalizes best? We implemented 4 models: logistic regression, decision tree, random forest, and support vector machine. We cleaned the dataset by removing missing values, recoded the outcome variable, and treated the category predictors as factors. After cleaning, 277 patients remained in the dataset. To evaluate the generalization, we used tenfold cross-validation for logistic regression and random forest, while decision tree pruning and SVM tuning incorporated cross-validation internally. Each model was assessed using accuracy, sensitivity, specificity, and the area under the ROC curve. That gives us a comprehensive view of performance. Logistic regression served as our baseline model. Malignancy degree was the only consistently significant predictor. The model performed well on the test set, with 80.9% accuracy and an AUC of 0.8. However, under cross-validation, accuracy dropped to 72.5% and the sensitivity to 36.9%, showing a signs of overfitting and bias toward the majority class, which was patients who did not experience recurrence of cancer. The decision tree used malignancy degree, tumor size, lymph node involvement, and the breast quadrant. The full tree achieved 83.3% accuracy, but was overfitted with 12 terminal nodes. After pruning, the tree generalized better, with 76.2% accuracy and an AUC of 0.63. The pruned tree maintained interpretability while reducing complexity.
Random forest aggregates many decision trees to reduce variance. It maintains stable accuracy across test and cross-validation, around 77%. Specificity was very high at 95%, but sensitivity was modest, between 27 and 42%. Variable importance plots highlighted malignancy degree, radiation therapy, tumor size, and lymph node involvement as key predictors. The linear SVM required a soft margin, confirming the classes were not linearly separable. To improve fit, we tuned a radial kernel using internal cross-validation, which selected the best parameters. The tuned radial SVM achieved 78.6% accuracy and 95% specificity, but sensitivity remained low at 27%. Because SVM relies on distance-based classification, categorical predictors were treated as factors, which are expanded into dummy variables to ensure valid distance calculations. Here we compare performance across models. Logistic regression and decision tree showed higher sensitivity but signs of overfitting. Random forest and SVM achieved strong accuracy and very high specificity, but sensitivity was poor. Overall, no single model was superior. Each had trade-offs between accuracy, sensitivity, and interpretability. These ROC curves illustrate model performance. Logistic regression in random forest achieved AUC values around 0.7 to 0.8, while the tuned radial SVM reached 0.73. The curves highlight the trade-off between sensitivity and specificity. Across all models, we observed a consistent trade-off. Accuracy and specificity were strong, but sensitivity was poor. This reflects the class imbalance in the dataset where non-recurrence cases dominate. Models were better at ruling out recurrence rather than detecting it, which is a limitation in clinical contexts. In conclusion, malignancy degree was the most important predictor, with tumor size, lymph nodes, and radiation therapy also contributing. Random forest balanced accuracy and interpretability best, while SVM achieved strong accuracy and specificity. However, all models struggled with sensitivity, raising concerns about false negatives. Future work could explore SMOTE, cost-sensitive learning, interaction terms, and larger datasets to improve performance. Thank you for listening. We welcome any questions or feedback.